Thanks very much, Roxanne, and thank you very much to the organizers, and congratulations for another great meeting. It's really an honor to be here. So, I have less grasp of the great data that Jazz just presented, so I'm going to try and take a little bit more of a pragmatic approach to this. I don't have any disclosures related to this, and obviously this is a debate, so these opinions don't reflect the official position of any of these organizations. So I'm going to start with the case here. This is a patient who had a single-layer DES restenosis, and you can see that the stent is actually hanging outside the aorta here. It's an 84-year-old, and just to remind you that in-stent restenosis is not necessarily benign. Many of you who are old enough may remember when drug-eluting stents were introduced into the United States, everyone said, restenosis, who cares? I'll just put a bare metal stent in and just treat the restenosis. But the reality is it's not that benign, and this is a patient who's admitted with an acute coronary syndrome. This patient had a history of a PCI at an outside hospital and got a 3/0/18 DES with no intracoronary imaging, and there was protrusion of the stent into the aorta. There was severe ISR of this, and this is the angiogram after predilation. I'll show you the low definition IVUS on the left-hand side, and this is really an undersized and, more importantly, underexpanded stent. Just to remind you that we used to think it was all about apposition in the early DES days. Now we know it's really all about expansion. And this patient, unfortunately, could have avoided a second procedure had their first procedure been done using intracoronary imaging. So over the next few minutes, I'm going to go over the treatment options for DES ISR, because again, we're not using bare metal stents anymore. And I do want to go through a little bit of data around the clinical data for the use of drug-eluting stents for drug-eluting stent in-stent restenosis. And then what I'll summarize with what I consider to be a reasonable approach to ISR. And the reason I say reasonable approach is that there are very real financial implications of using DCB in the United States. There is no reimbursement for DCB currently used in the coronaries, and it is $5,500 per balloon. So you have to make sure that you're targeting the patients appropriately so that you don't end up bankrupting your cath lab. So this is a terrific review article that was published in Davide Capodanno's journal by Fernando Alfonso, looking at mechanisms. And I want to talk also about the goals of therapy. So there are stent-related factors, like the case I just showed you, underexpansion, undersizing, et cetera. Stent fracture, we used to see a lot more with thick strut stents. It was about 11% in the CIPHER trials of CTOs, and the across CIPHER was 11%, mostly in the right coronary artery. We don't see that much anymore. There are intra-stent factors like neoatherosclerosis that can occur, well beyond a year after drug-eluting stent placement. And then there are extra stent factors, multiple stent layers, which I guess is what I'm charged with talking about, but then vessel calcification, which we've seen a lot of today with these live cases, and I think emphasizing the importance of adequate lesion preparation. So what are we actually trying to do? Well, we're trying to maximize net gain. Okay? So immediately after PCI, you do get acute gain, but there is some degree of late loss even with drug-eluting stents. So ultimately, for the patient's perspective, they want to have an open vessel. No one comes into your office and asks you, what was my net gain, doc? What they want to tell you is, are their symptoms relieved? So, but the way that we can relieve their symptoms is obviously to increase flow, and if you maximize net gain, you can salvage more myocardium. Our therapeutic options, as you know, are balloons, and I've included IVL under specialty balloons because cutting balloons, high-pressure balloons like OPN and IVL are really there to make sure that that stent that was placed previously that has in-stent restenosis is adequately expanded before you do the second treatment. Atherectomy can also be very, very helpful in these cases. And then ultimately, after you do the lesion preparation, you have two choices, either the DCB or the DES. So let's talk about the clinical data comparing these two platforms. This is a little bit of a busy slide, but again, a terrific article by Fernando in Eurointervention looking at the landscape and the history of the treatment of ISR. And you can see that the two options that we're really talking about here is we're not talking about comparing DES with plain old balloons. We're not talking about comparing DES with cutting or scoring balloons. We're really talking about comparing drug-eluting stents versus drug-coated balloons. And I do want to talk about agent because I think it's interesting to dive into the details of this. Jazz did go over this. This is a randomized trial of the agent DCB, randomized 2-to-1 against balloon angioplasty. That's a common design for device trials so we get more safety data. And the primary endpoint, as you all know, did favor the paclitaxel-coated balloon compared with uncoated balloon. But let's peek under the hood here a little bit. These are the baseline angiographic characteristics of the patients that were randomized in the agent IDE trial. More than half of these patients had a single stent layer. Okay? Only 43% had multiple stent layers. Now think back to your own practice and tell me what you're doing with single stent layer in-stent restenosis. This is that same meta-analysis that Jazz showed you. The left side we're going to ignore because it's bare metal stent in-stent restenosis. But if you look at the pooled data of all the randomized trials that have compared drug-coated balloon with repeat drug-eluting stent for single-layer DES restenosis, what you see is that it favors drug-eluting stents. So for single stent restenosis, there's no question that the data favor DES, repeat DES placement, provided that you prep the lesion adequately and you make sure that you get adequate stent expansion. So what's my reasonable approach? Well, I think if you have single-layer DES ISR, make sure you do intracoronary imaging to identify the mechanism. Make sure you get adequate lesion preparation with specialty balloons or atherectomy as needed. Repeat the intracoronary imaging, just to make sure that you've got calcium fracture and make sure that the stent is expanded. I would, personally, for single-layer DES, I think the data favor repeat DES with post-dilation and then repeat the intracoronary imaging for adequate expansion. But what if you have double-layer? The only differences here, in my mind, is that you absolutely have to make sure that you have adequate lesion preparation because you're not leaving a second layer behind, or a third layer, rather. Repeat the IC imaging, and in this case, you can use the DCB, and again, repeat the IC imaging. So in my opinion, I think that for single-layer DES ISR, repeat DES is appropriate. For double layer, it is very, very important to make sure that you have adequate lesion prep and you can use the DCB. So in conclusion, DES ISR is unusual, but it still does occur. Identification of the mechanism is essential to drive your therapeutic options. IC imaging is fundamental. DCB certainly is a technological advance. We're thrilled that we have it now in the United States, but in my opinion, it's really ideal for multiple layer DES ISR. But for single layer, that's a typo there, for single layer, really just stent it. Thank you very much.